Hello. Hello, everyone. Good evening. I welcome you all. I welcome the distinguished faculty and all the delegates who have logged into this webinar, which is being organized by the Obstetric Gynec Society of Hyderabad with an educational grant given by Bharat Serum and Vaccines, and we have Science Integra as our academic partners. So welcome and good evening to everyone. We have an interesting lineup of topics. The most important, of course, is endometriosis for all of us gynecologists. And of course, we have topics on COVID testing and massive blood transfusion. A very interesting faculty also. I welcome you all to this webinar. And it is my pleasure to introduce Dr. Vindhya Madam as the chairperson for this webinar. She, of course, needs no introduction to all of us sitting here. She is the consultant at Apollo Hospitals, Hyderabad, and the president of OGSH. And she, along with her dynamic secretary, Archana Singh, have been steering OGSH in these difficult pandemic times and organizing so many webinars for all of us in the OGSH. And she is also the executive member of Vijaya Foundation Trust, an NGO for women and children. So, Vindhya Madam, welcome as the chairperson of this webinar today. And Dr. Shanta Kumari, who is our president-elect FOXY 2021, will join us very soon in our webinar today. So, we will eagerly look forward to her participation today here. Our first talk is by Dr. Archana Singh, who is the secretary of OGSH, who along with Vindhya Madam is working behind the scenes to organize so many webinars as part of OGSH. She will be speaking on Dynogest. So over to Dr. Archana Singh, and Vindhya ma'am, please take over as the chairperson. Thank you.
Good evening, everybody. Thank you for the nice introduction. Am I audible to all?
Yes.
Thank
yes.
you. Endometriosis management will be dealt in detail today by panel discussion, but in short, I will discuss about Dynogest. As we know that endometriosis management is shrouded with controversies. Rather, we still have a long way to go to find exact treatment for endometriosis. So the aim is complete resolution of endometriosis, which is not yet possible, and current therapy has three main objectives: to reduce pain, to increase the possibility of pregnancy, and to delay recurrence for as long as possible. So what we are having besides surgical treatment is the medical management, where first line is combined oral contraceptive pills and progesterone only pills. The second line we go with GnRH agonist and others like danazol, aromatase inhibitors and NSAIDs. So coming to Dynogest, selective progesterone receptor agonist, which is a 19-nortestosterone derivative. It is having a potent inhibitory activity on the growth of endometrial tissue, which is the main action of it on endometriosis. So how does Dynogest act? The central effects as well as the local effect. The central effect of inhibition of gonadotropin secretions, hypoestrogenism, then the ovarian function, the anovulation. The local effect is because of the anti-proliferative phase, anti-inflammatory effect, and anti-angiogenic effect, which reduces the size of endometritic growth. Then it is very easily available and oral agent, single dose 2 milligram per day. So compatibility with the patients is good. Patients are happy with single dose, short plasma half-life, about 10 hours, and high oral bioavailability, more than 90%. And what it does, it alleviates the endometriosis related symptoms. Dyspareunia from 51% to 7%, and dysmenorrhea, diffuse pelvic pain and premenstrual pain. No notable effects on lipid, carbohydrate, and liver metabolism is seen. Then it also suppresses the ovulation at 2 milligram, but non-hormonal contraception should be advised for the patient. It is not to be used as a contraceptive. Acceptable agent for monotherapy, approved as monotherapy agent in Europe, Japan, Australia, and Singapore. So although it suppresses the ovulation, but alone it is not ideal contraceptive pill. Then Dynagest in rectovaginal endometriosis, as such, we may need surgery in most of the cases, but still 24-week study of 25 symptomatic patients, decrease in intensity of dyspareunia has been seen and improved quality of life and sexual life after 6 months, and no significant change in the volume of lesion. So this is important, although the change in volume of lesion which we want is not there, but still the pain has reduced, so their quality of life improves with the use of Dynagest. Then coming to Dynagest versus Luprite, equally effective in reducing symptoms, and it has minimal change in bone marrow density compared to other drugs, and no hot flushes, which is the advantage, and more compliance from patient side is seen because of these beneficial effects. Then coming to beneficial effect on pain, it is not only during the treatment it reduces pain, it exceeds the period of treatment. And E2 level maintained in low physiological level and superior to gonadotropin in bone marrow density, because it is less bone marrow density is reduced in this rather than in gonadotropins. And potential for effective long-term treatment is there, but still needs long-term studies. So Dynagest containing pill provides a long-term effect in endometriosis management and improves the IVF success in women with adenomyosis and IVF failure. So there are side effects also, but most important is problem with the initial bleeding irregularity. But here the intensity and frequency reduces on continuation of treatment, and later progressive reduction in bleeding days followed by amenorrhea can be there. So the most important is that we have to counsel the patient regarding the bleeding abnormality, and if she continues the treatment, that will result in better outcome rather than stopping the treatment because of bleeding irregularities. Then other side effects are headache, which can be seen in 9 to 18%, constipation not so frequent, but still 10% have complained of mild degree of constipation, breast discomfort because of the progesterone effect, and yes, 5% complain of depressed mood. Acne also 5%, so we have to counsel them beforehand before starting Dynagest. How long Dynagest can be given? So 52-week study has been done, and it has been found that it could be given according to Obstetrics Journal 2017. Effective and well tolerated for 12 months, effective in reducing pain on 12 months use of Dynagest. So it can be given for more than 2 years without any serious side effects. And if we stop, then menses resumes within 4 to 6 weeks. And from 29 days to 2 months, in 97% fertility comes back.
Tolerated for 12 months, effective in reducing pain on 12 months use of Dynagest. So it can be given for more than 2 years without any serious side effects. And if we stop.
And so to come for take-home message, an effective and generally well-tolerated treatment option to reduce pain, to reduce lesions, improved quality of life, has an acceptable side effect and suitable for long-term use. But at the same time, it is not always the completion of lesion removal by Dynagest alone, and many of the time patient may need surgery also. It is good when we are planning for a conservative management, or for short term when the patient doesn't want any surgery, then Dynagest is definitely an answer for those questions. Thank you for your patient hearing.
Alone, and many of the time patient may need.
Thank you, Archana.
It was very brief, and I think we got the message what Dynagist is and its uses and side effects, everything. If anyone has a doubt, they'll ask you at the end. After the panel discussion, I think it should be good at that time. Now, I think we'll welcome Dr. Manjula Nagani to go ahead with her panel discussion on the management of endometriosis with her eminent panelists. And she'll introduce you to all her panelists. Yes, Manju. Where is she? To go ahead with her panel discussion on management of endometriosis with her eminent panelists. And she'll introduce you to all the panelists.
Mute. Right. So I have the esteemed panelists with us. That is Dr. Garuda Lakshmi, professor from GMH, and Dr. Asha. We all know Asha from such a long time, but the best part of it is right now she's so active into the obstetric and gynecological society. We can see so many webinars being done and question answer sessions being done by her. She's standing from the West Zone as a vice president, so I'm sure all of you know her. And then we have Dr. Narasimha Reddy sir, professor from well-known surgeon and gynecologist from Warangal. And we have Dr. Neeraj Yanamandra, a gynecologist laparoscopic surgeon from Rainbow. Welcome all my friends. Gynecological Society, we can see so many webinars being done and questions being done by her. She's standing from the West Zone as a... So what I want to start off with, we are going to have this wonderful panel on endometriosis. So when an endometriosis, especially when a recurrent endometriosis comes, this is how we all feel. This is general practice approach. We are like, how to go about and all. So hopefully today, we will have some answers. We'll have this enigma, which is going to be cleared, clarified by our eminent and panelists. So endometriosis has always been a diagnostic dilemma, debilitating disease. It's a progressive disease. It's a recurrent condition, and we only talk about chronicity and no permanent cure. So what is it? And we have so many guidelines on endometriosis. RCOG comes, ACOG comes, ESHRE comes, and then IAGE comes. So, and the laparoscopic surgeon and IVF specialists always fight on it. So let me ask you, start off with a few questions. I always thought about, why are we in search of new things with endometriosis? What is it which is needed? Current options and the fertility role. What to do, what not to do, and when to do, when not to do. So I hope by the end of it, we will have this question. So my first question to Professor Dr. Garuda Lakshmi would be, why are we actually searching for new? What is the need for new things in endometriosis? Isn't it what we know is already enough? Dr. Garuda Lakshmi.
Madam is muted.
Question to Professor Dr. Garuda Lakshmi.
I'm so sorry. I guess Dr. Garud Lakshmi is also watching the webinar online. So we are making a double.
What we know is already enough. Dr. Garuda Lakshmi, please stop watching online. Can you off that and directly watch this only?
Yeah, I'm directly using.
Yeah, please. Because what will happen is there's a time lag which comes between what we talk and what is being presented.
I'm so sorry. I guess Garud Lakshmi is also watching.
Yeah. So what do you think? Is there a need for the new things which we have to know? And is there a discrepancy from what we already know, or is it what it is stagnant?
I'm directly using.
Okay, I'll be putting this question which comes between what we talk and what is being. Dr. Neeraj, would you like to answer this, please?
Yeah, I mean, we are in constantly looking for new treatments because we're not satisfied, we're not happy with the existing ones. And when you look at the symptomatology of the patient, if it's about pain, then we have several medical methods, yes, but none of them is something which we can give in long term. And again, if it is overlapping with symptoms of infertility, for example, then we don't have one definitive treatment which we all are satisfied with, which will work, for example. Therefore, we are looking for newer modalities which will have better compliance, less side effects, and will give desired effects based on what the symptom the patient is presenting with.
Yeah. So, Dr. Neeraj, the whole purpose is, I think, we don't know anything for sure with endometriosis. Incidence also keeps varying depending on region and the type of diet we are taking. Symptoms keep varying, and it is like usually 10 years by the time we actually diagnose it, and recurrence is such a norm. So that's the reason why we keep on searching for the new thing. So what do you think is the new thing which we learned in the recent times? I mean, we are stressing in the recent times about etiology.
Yeah. The thing is, all these theories which we have read as medical students about Samson theory, which was the most popular one, which still remains the popular one, that doesn't explain different questions on endometriosis, especially odd locations of endometriosis, which we find in retrograde menstruation, you won't find in lungs and brain. But endometriosis has been identified in those areas.
Yes.
Therefore, there has to be another theory or theories which will explain how endometriosis actually occurs, which may mean embryonic coelomic deposition at the time of embryogenesis outside Mullerian duct or outside extrauterine sites. That explains probably why women at puberty may develop endometriosis or symptoms of extrauterine.
Metaplastic theory holds more better.
So Samson probably was wrong, or he may be right to a certain extent, but doesn't explain many things in endometriosis. That is what the enigma is about.
Right. So I think Dr. Neeraj, what you said is absolutely true. Samson holds true only when retrograde menstruation happens, but otherwise rest of the time it is the metaplastic theory where there's metaplasia. But why is metaplasia happening? What is the irritant? So I think in the recent times more stress is being done about the endocrine disrupting chemicals. So endocrine disrupting chemicals, especially in what all we eat and everything, like the environment, that is dioxins and TCDD, PCP, they cause chronic inflammation and they act on the gene processes. And the way it happens is there is a disruption of the progesterone dependent remodeling responses. So the way progesterone acts is inhibited. So it's no longer what we used to think like estrogen dependent disease. It's not a estrogen dependent disease. It is a progesterone which is ineffective because of whatever is happening at the aryl hydroxylate or the receptor level. So that's the reason. That is one point I wanted to make at this point.
Can I comment? Can I comment? Can you? Yeah, no, it will, the Samson theory is supported by Benson and Benjayano. It will start from the new birth. So the implant from the newborn with bleeding. So after puberty, this new implant is grown with estrogen and progesterone. This is a new theory. Yeah.
No, so many theories are there. Betaplasia and Samson, everything works depending on the thing. We are talking about the extragenital when we see. It is a metaplastic which is increasing in the recent times. And the metaplasia is because of the exposure to the endocrine disrupting chemicals. That is the new thing which we wanted to tell. So Dr. Garudalakshmi, coming back to you, what is the new thing about the staging which you would like to tell our audiences?
So nowadays revised ASRM guidelines is one. And another for fertility is enhanced fertility index. And new one is for deep endometriosis, very important for preoperative is NZN study. And fourth important is where they included even subtle lesions is conics staging. So all these three combined staging is very important. Whereas this revised ASRM staging is important because it is universally accepted.
Right.
Yeah. It doesn't give much importance to deep endometriosis, deep infiltrating endometriosis.
Right. But practically, when we have to look at it, we have to differentiate depending on whether the patient is suffering from pain or infertility and then divide it. If it is pain, usually we label it as like superficial or DIE. There's a deep infiltrating. When it comes to fertility, like you said, the revised ASRM, but in actual result sense, it is the EFI, that is the endometrial fertility index, which makes sense. NCN and all have come, but it has become more cumbersome. It's not more easier than to do it. Dr. Asha, can I come to you?
Yes, yes.
Yeah, so what is a new thing apart from diagnosis? We all know that we talk about the gold standard is laparoscopy. When you see it is there, there are so many times people present to us, nothing is visualized. CA125 can be borderline 65, 75, but no ultrasonic picture, no MRI is okay. You put a telescope and see, but nothing much is there. But what is one thing which you think? And when you take out ovarian cyst wall and you send it for histopathology, and they would say hemosiderin laden macrophages. They would never say it is endometriosis. For them, it is the lining, that is the endometrial lining which should be there. If it is not there, they're not going to comment. So what do you think is one thing which can clinch the endometriosis mimickers from the endometriosis? What is the latest thing you think is the new thing which can help?
I think new thing is that it is being considered that endometriosis is an inflammatory process,
Right.
and many biomarkers are being looked for, which can guide us towards the incidence of endometriosis, like macrophages and cytokines and vasoactive growth factors. So lots of things are being investigated into it. Still, we do not know what will really exactly tell us. But if you combine few biomarkers, the clinical scenario, the findings, then you may get more. And maybe, as you have already written here, that immunohistochemistry may further aid to the diagnosis.
Right, absolutely true. So we've been using gold standard, that is laparoscopy, but clinical suspicion, high degree of suspicion, ultrasound if endometrioma is there, color Doppler if necessary, MRI, all that is perfect. And like we know, CA-125 is prognostic, but biomarkers is clinically actually practically not much available, and it does not make ring. But one test which is making difference in the recent times is the immunohistochemistry, which is quite cheaper, maybe around 1,000 rupees per case. Whenever we have a doubt, send it for CD10. If the CD, because every pathology lab, good pathology lab, have immunohistochemistry because of cancers and cancer mimickers. So CD10, if possible, positive in the stroma, it is seen in the stroma, it is 100% endometriosis. If CD10 is not there, then it is a mimicker, something else which is presenting. So this is the huge breakthrough which we have in endometriosis in diagnosis.
It's very important because many times there are endometriosis associated occult tumors also. So if we really prove it through immunohistochemistry, it would be a great idea. So I think I totally agree with you.
And without much ado, I just want to run into the clinical scenarios. I'm sure most of the audience will be waiting for how we are actually going to manage the cases which we are going to present. So but in an overall approach of the treatment, I would like to say that we have to recognize the goals. Is it our goal to decrease the woman of the pain or fertility, or consider the disease factors like we have discussed just now, and the patient factors like comorbidities and the other thing, like any other immunological conditions which the patient has, and discuss with the patient very clearly that it is a chronic disease and we are not talking about the cure, and optimal treatment is unproven, non-existent, but something nearby is something which we can offer. And appropriate therapy is always multidisciplinary, and a plain clinic and counseling also might be needed. So now we come to Dr. Narasimha Reddy sir, our professor from Warangal, very famous and very good clinician. Sir, we have this young girl, 18-year-old, unmarried female, presenting with progressive dysmenorrhea, periodic bloating for 3 years. She is always accompanied by the mother who wants to interfere in everything, who wants so many questions which has to be answered. And she always like no surgery, only medicines. Okay. So previous periods have been, the cycles are regular, but 2 to 3 days before the periods means congestive dysmenorrhea, but relieved with analgesics. One side she has to give analgesics, she is not going to the school for 3-4 days, and other side she is worried about analgesics and any medicines. They want to have no medicine treatment. Ultrasound normal, everything else is normal. So what type of a thing, what is a high degree of suspicion you would have, and do you do CA-125 as a routine in such cases, and do you think MRI is needed, and how do you want to manage her? Dr. Narasimha Reddy sir.
I'll come in the reverse manner.
Yes,
MRI
sir.
is absolutely not required.
Right, sir.
CA-125, I won't do it.
Yes, sir.
Clinical CA-125 also, I won't do it.
Yes,
ultrasound, of course, said that it is normal.
Yes,
it could be spasmodic dysmenorrhea, and here it is
congestive dysmenorrhea. She has a congestive dysmenorrhea.
Yeah, 3 days early and subsequently also.
Yes.
So I'll treat these patients on clinical grounds only, on clinical examination and history, with the medical management only.
Okay, sir.
Won't
So what's
advise
the
any
management you would? How would you counsel the main hurdle here is not the kid; it's the mother. So how do you counsel the mother regarding the management, and how are you going to go forward?
So see, it's a starting just 3 to 4 days before the menstruation. Usually I'll say that, we will stop, at least we will make many of these cycles anovulatory.
Right.
Most of the anovulatory cycles are going to be painless. So I'll try to convince the patient that you are going to have regular cycles with pain-free.
But so the mother does not want any hormones. She's worried about hormones. How do you want to tell?
This is not the hormones, because the hormones are going to be there in every woman. Yes. What we are going to give you the same hormones which you have got in your body. See,
Right.
we are not going to do any extra thing, and we are going to give some hormones which will suppress the ovulation. Subsequently, you will be relieved of the pain, and cycles also will be regularized. So
Okay.
I'll convince the patient so that go for the oral contraceptive pills in the first place in this scenario.
Okay, sir.
I never go for any further investigations until
Right.
if I fail to convince the woman, or patient comes back even with 3 to 6 cycles of oral contraceptive pills, probably I may go for the other investigations.
What?
Otherwise, absolutely no.
So what investigation at the end of it? Even then the ultrasound is normal. After 6 months, her pain is still continuing, and pain is decreased on the cycles. After 6 months, you have given a gap, and again the pain has come back. And what would you do? Because ultrasound is the same.
Yeah. Many a times I may go for the MRI instead of a laparoscopy.
Okay, so
Because
MRI
it's a
is also,
unmarried
MRI
girl.
is MRI is man behind the machine. It is nothing to do with the machine. The machine says normal. Then the report comes normal.
Yes.
Then subsequently, if the patient, I may go for the progesterone only pill in this lady.
So till now, sir, my point is till now you have not diagnosed. This is an empiric treatment you are giving, facing that high degree of suspicion. So would you like to diagnose in this case now? Because the mother is worried. She's going to shift from doctor to doctor. Or you would like to continue the empiric treatment?
Yeah, usually if I won't find any mass lesions in the pelvis, either in the ovary, nor in the pelvis, nor in the abdomen, probably I may not go for the invasive procedures, because invasive procedures are always associated with some apprehension to the woman, and subsequently they will be caused. So I'll go for the progesterone only pill in this scenario.
Okay.
Next
Sir,
my option is
Dr. Neeraj, any other thing would you want to add to this?
No, I don't want to repeat all that sir has already said. I agree with what
just
he said.
addition, that's it. If you have to add it.
I find you difficult. You're not getting convinced by his answers.
Yes. No, I'm not convinced is not the thing. Imagine I have a teenage daughter, and as a mother, I'm not convinced.
No, listen. No, it's about educating the mother and the daughter first, telling them that this is not going to be an overnight treatment.
So she is going to tell, you are giving me, my daughter, hormones without even diagnosis, without even anything. I don't want to give hormones to my daughter and this thing.
One thing we can do is, if at all, I mean, obviously, because she's unmarried, 18-year-old, we can do a rectal examination just to see whether there are any palpable nodules.
Nothing is there. No palpable nerve.
Then we just have to work on a empirical diagnosis of endometriosis, explain them that the only way we can diagnose is by doing surgery, which is really not something which I would do in this young girl of 18-year-old.
If you do surgery, what do you think you were going to see there?
I mean, there may be superficial lesions which will not be seen on any by any imaging. So you can still expect minimal to moderate mild endometriosis. And this is the problem with the staging.
You might still see something else. This is a case of a teenage endometriosis.
Yeah, it can be adenomyotic patches on the uterus we can see. It can be superficial. Now, again, in the history, I don't know whether you have shown, I don't think. We need to find out whether she has anything like non-cyclical bowel symptoms in terms of...
She does not have non-cyclical bowel symptoms. Yeah. She has regular cycles, only congestive dysmenorrhea. This is a typical case of an adolescent endometriosis, where you will not see in POD mostly. You will see most of the superficial also little lateral para only.
Yes.
Yeah. So, anyway, my point was, Dr. Asha, anything else is striking in your brain?
No, I don't think so. What he has said is correct.
No, perfectly. What everybody said, Dr. Garuda Lakshmi, any additional?
Explain to her that if she is getting benefited by the pill, then maybe there is...
Don't you all want to see if she has a septum?
No, any Mullerian anomaly.
Yeah. How do you want to tell? Because this is a teenage girl, the scan is being done. MRI, okay, Dr. Sir said after 6 months I will do an MRI. Perfect. So high degree of suspicion of any Mullerian anomaly should be thought of in these teenage endometriosis. It is a different scenario than the regular patient. So what does ACOG tell us? Empiric treatment, perfect. Conservative, perfect. It has to be first is medical, perfect. But 2 points of thing I want to tell about teenage endometriosis. One, high degree of suspicion of Mullerian anomaly should be thought of. Second, the treatment should continue till the girl thinks of pregnancy. That means she'll have to continue for 5 years, 7 years, 8 years. So you have to have a high degree of patience to convince the mother and the child about it. So we have to tell them that there is no cure. Long-term medical management is the treatment for this. And till she thinks of pregnancy, she has to continue because it is a progressive disease. So empiric treatment, if she's younger than 18 years, it has to be combination hormone therapy and NSAIDs. If she's older than 18 years, you can try GnRH. And then if the pain comes down, then that is the way of diagnosing the endometriosis. So you can give a therapeutic trial of GnRH and tell her this is endometriosis for sure. That is, don't give more than 2 or 3, just the thing. Less than 18 years, please do not give that also, because it has a more bad thing. So role of diagnostic and therapeutic, it depends again. This is the nomogram for teenage endometriosis, where it is clearly said that if your high degree of suspicion after 6 months comes down, if it's more than 16 years, you can give GnRH endobac and then change over to continuous CHT. Once the hormones start, no pain, continue that till she thinks of pregnancy. Now, if there's a continued pain in spite of the combined treatment, then go for laparoscopy. I hope I could make that one extra point which I wanted to make. So it is the treatment for teenage endometriosis is multidimensional approach. Goal is pain and suppression of disease progression and preservation of fertility. This is the thing with teenage. So I just wanted to add this point. And Ashray also says that non-medical is not much helpful. So these are the established medical, which is...
If I may add, is gonadotropin releasing, GnRH analogs at such young age.
Not before 18, after 18 years. This is for therapeutic. After 18, that also only for a therapeutic, the trial for a diagnostic, therapeutic trial. To know that, to confirm that it is endometriosis and not anything else.
Sure, I thought it was...
Definitely this. And nowadays, NSAIDs is inconclusive, but it is appropriate for young in medical managers. And hormonal, you should be looking at COC. Duration depends on the thing. In adolescent, it has to be till they think of pregnancy. And GnRH, if you're adding, add back. In LNGIUS, yes, there is a role even in teenage, because if people don't want to take combined pills for a long time, you can just put LNGIUS for these kids, especially when it is this thing. Dynogest, in today's time, you can next think of after combined pills. If you are very much worried about combined estrogen progesterone pill, you can look at Dynogest. But already Dr. Archana told all the pros and cons about this, how it acts and everything. So guidelines, when you see for any other thing, definitely go and surgically treat it. See and treat for teenage endometriosis. That is what is the main point. Even if they're asymptomatic, we don't have to do anything. This is the case I have to say about you can see a small surface endometriosis there. We removed that small thing and sent it for CD10, came positive. And there was a subseptum in this girl, which we have cut. And after that, only the patient pain has come down. So high ultrasound will not show the subseptums and all that. So we have to be thinking, and clinical high degree of suspicion is important. I think we have another half an hour. So I'm going to case 2. 20-year-old female complaining of severe pain, RAF, lower abdomen, 3 to 5 days, vomitings, acute pain. She came at 2 in the night, middle of the night. Rest of the things are normal. We sent her for the scan. In fact, CT scan was done for her in the middle of the night. And they said it is 7 into 7 centimeter right endometrioma. Query looks like free fluid is there. Looks like ruptured endometrioma. But they also said query and appendicitis. Now, 2 in the night and a CA125. This CA125 was done before, not in the night. I was around 49. Now, in this case, diagnostic dilemma of whether endometriosis versus appendix has acute cause. So, if you're going in for one thing, do you want to do the other thing? And in this case only, I want to talk about the cystoscope, cystectomy with vasopressin, and role of posterior broad ligament excision. So, I would like, who's going to take it first? Your choice.
No, I'll take it.
Yeah, take it, Dheeraj.
So when you say technique of endometrioma excision, this lady clearly, regardless of the time, even if it is 2 a.m.,
yes,
if there is suspicion of free fluid in the pelvic and abdominal cavity, you can't rule out appendicular perforation, which you cannot sit on. It is an acute abdomen situation. You have to do laparoscopy, because endometrioma rupture I have not seen. It's very rare. So endometriomas don't rupture and give acute picture. They neither tort also. So they don't undergo torsion. They rarely undergo rupture. So my presumptive diagnosis will more be on appendicectomy. White cell count is also slightly raised, I think 12,000. with vomiting. So it gives me picture of acute abdomen. Regardless of the time, I might put the scope in. Now, technique of endometrioma excision. Again, because this is a young lady who probably did not have children, it will be as conservative as possible.
Right.
There will be a debate about whether you go for excision of a endometrioma or do a drainage and coagulation. Now, that debate is, I think, definitely answered.
No debate in that point.
Nowadays,
it's completely answered that excision is the best one,
yeah.
Especially when you talk of recurrence point of view, reduction of pain point of view, improving quality of life, and more importantly, even from infertility point of view, excision is the best thing to do. And appendicectomy, yes, I mean, if it gives an acute picture and it looks like there is a concurrent appendicitis as well, we can go ahead and do appendicectomy.
You would do it, or you would call a legal aspect of it?
I'll get a surgeon to do it. I mean, I can do it, but again, getting into the legal aspect, it may be in this day and age better to
legally, if it's an emergency situation and you have gone in for this, will you not be, I mean, you are not expected to do it?
If you can do, I mean, I can do it, therefore I'll do it. But I'm saying of a generalist from everybody's perspective, yeah. Not many gynecologists will be trained or will feel confident in doing appendicectomy, and that's fair enough.
Right.
So you can get a surgeon involved. That's not something which is difficult these days. All of us have phone a friend somewhere available who can come and help you out. And then vasopressin, yes, it's a very nice, which is what we do, and most of us, I believe, will be doing vasopressin to reduce the blood loss and even to get better plane. That it gives you a better plane of excision and reduces the vascularity as well. So at the end of cystectomy, you may not need any diatherming or using more energy source which will only destroy follicles further. And it may also may not need suturing of the ovary at the end.
Right.
So that answers almost all the questions. As far as role of posterior broad ligament excision is concerned, I don't do it, and I don't think it's something which has a very strong evidence for us to go and do it. And in this particular lady, why? So I won't do it.
Not in this particular lady, but generally you would do it or no?
No. And one point, Manjula.
Yes.
So any case before endometrioma, it is better to do AMH levels. So you can counsel if there is a decreased ovarian reserve. If you do AMH, it is due to the distraction of it is not due to the surgery. So better to do AMH levels before any surgery on endometriosis. Is my opinion.
She came as an emergency, no, madam.
No, this case
is emergency. Probably we may not do it.
Yeah.
We may go for as per the clinical findings.
Not this case. For any case of endometriosis, before taking up, it's better to do, if there is a time, do AMH levels before surgery. Yeah.
Okay. Anybody else? Yes, Dr. Asha.
Posterior broad ligament excision, actually peritoneectomy that you do.
Right.
And there is one paper from Florence, and that suggests that these endometriomas, they are adherent, where they are adherent on the posterior broad ligament, the recurrence will occur. And in that particular study, they found that when they removed this, the recurrence was much less and the pain was also much less. So maybe, though occasionally we have done it, but maybe doing it would be a good idea.
We do it on almost every case, especially because it decreases the recurrence and the pain, the amount of pain reduction after this thing, because the incidence is not just when we talk about DIE, we talk about deposits. When you're talking about Samson theory,
it's deep inside.
It's always inside the peritoneum, and it is not just on the ovary, it is almost always in the broad ligament, and especially the left side. Coming to it in surgical management, we all know, we all agree, ideal practice is complete excision. Ablation has no role. Luna has no role. Radical surgery, we'll come back to it. Pre-op hormonal treatment in regular any patient comes, not this case, is no justification. Post-op, yes. So don't waste time for anybody who is coming with endometrioma with pre-op, whatever says, danazol or GnRH for 6 months, and then post-op LNGIUS has great outcomes, especially in decreasing the recurrences also. Ideal regimen for HRT is still not recommended. So traditionally, we have been doing, depending on the ovarian reserve prior to treatment, like Dr. Garudalakshmi madam said, and laterality, location, age, and prior treatment. Depending on these 4 factors, we have to decide. Traditional surgeries have been cystectomy, aspiration, and endometrioma ablation. But now, what Dr. Neeraj said about the aspiration and then going back, and 3-stage technique was originally told by Dones. That is just aspiration, then coming out, giving GnRH analog, and again going back and doing the surgery. But now we have come over to combined ablation cystectomy, where 90% will be removed, and near the stroma we can just do ablation. Cystectomy with vasopressin, what Dr. Neeraj said is perfectly all right. The three major factors which are there, we will come to it. Or you can, if you are not able to do it, after removing it, there is a lot of bleeding, just put a Sergi seal or gelatin thrombin mattress seal and come out also. Aspiration is sclerotherapy.
Let me ask you, Dr. Manjula, 1 minute. In the previous slide, you showed danazol. Do you in your practice give danazol?
No, no, not at all.
No, that's what, because I saw
Where
it.
is danazol written?
Yeah, it is written somewhere.
It is given. This is a recommendation which was given, but no evidence level.
We're not using anyone, right? I'm
We
sure
don't give at all. We don't give at all.
Usually, Manjula, if the pain is very intractable and not settling down with anything, then people have used danazol, and in those cases, it gives good result. And nowadays, they are trying to make danazol vaginal rings also.
Yeah, rings.
Can control the pain. So,
which is very bad for danazol.
Maybe.
Manjula, one question. If she wants pregnancy immediately after surgery, it is better not to give post-op management immediately.
It depends a lot.
It
depends a lot on whether she wants to wait 3 months or not, but the results are very, very clear. Even post-op 3 cycles of GnRH analog and then going for IVF has better results than not going. So when we have to weigh between the recurrence versus the infertility, 3 months is something most of the people would actually opt for.
No, but severe, if it is a minimal or mild or moderate,
no need to wait.
No need to wait. That's what I'd say.
That is the infertility.
Then no need.
So these 3 points.
Really want to go after the surgery, then better to wait for 5 months and then go for surgery. There is a very good paper, and that says that instead of going in first 3 months, try to go after 5 months, and then you may get better results. So maybe you can use ultra long down regulation protocol and then go for IVF.
So the IVF specialist has spoken, so they'll get a better results after 5 months, so we will give the thing. So vasopressin, actually Dr. Thing has already told, I don't want to waste time with the videos anyway. You want to see, I think. Okay, grant access, fine. So this is what we usually do when we do it, and when the cyst comes, I just wanted, I'll go for faster. So from the lateral side when we do it, and we completely restore the anatomy. That should be the first thing what we do. And once we do it into the cyst wall, hold it. You can see it here. We give a vasopressin into the cyst wall. It gives the hydrodissection plus avascularity plus no need of any other. You can see how it just bulges out, and you can actually see how neatly it's going to come out. I just will do it very fast. See. It just comes out, peels out without any bleeding happening. So that's what it is. I don't want to waste. Next slide is about PBL. See, when there is this grade 4, the pain is the intracting. So what we do is we give vasopressin again into the broad ligament. And once we give into the broad ligament, the whole layer between the ovary till the uterosacrals is gently peeled off. So when we do this peritoniectomy, the recurrence plus the pain both come down drastically. So this is the study which tells that about that. So many studies, in fact, it says it's rarely 1.6% only. It is rarely confined to ovary. Majority in 70% it goes into the peritoneum. So recurrence rates within 1 to 2 years is why it becomes very, very low, less than even 1% if you do PBD. Long-term pain relief, as much as 98% pain relief will be there. So practically we do it, and then the pain is drastically low. Coming to the third case, we have 29-year-old female married for 3 years. This is the case for infertility. So this case, I'm going to throw it to Dr. Asha. So this is the case. Main thing what I want to know about this case is infertility. And the ultrasound is showing the endometrioma. Right side is a follicular cyst. So in this case, first of all, I want you to give a basic answer that how does this endometriosis cause infertility? And here you would jump to ART or surgery. And suppression of ovarian function to improve fertility, like we are talking about post-op. And what are the fertility preserving techniques you would think can post-op Dynogest GnRH? I want you to answer them. Then we'll take expert opinions from the others. Dr. Asha, your voice.
Madam, you only have muted. Please
Me,
unmute.
I cannot. I think the support.
Yeah. So now about the endometriosis causing infertility, I think it has been an observation that mostly infertile patients, they tend to have almost 30% patients tend to have infertility, and almost 30% of endometriosis patients tend to have infertility. And the causes are exactly not known, but there may be a defective folliculogenesis and less number of follicles may be formed. The quality of oocyte, though nowadays they are saying that the oocyte quality is not affected, but there was a question once upon a time, and the pickup of the egg may be affected. So the mechanics of the oocyte pickup may be affected. There may be anatomically disruption of the tubal factor may be there, and the transport system may get affected. Or it has also been suggested there is lots of toxic changes are going into the body and so into the endometrial cavity. So maybe the endometrium becomes less responsive to progestogens, and there is a defect in the implantation. So lots of theories are there about the cause of the infertility in cases of endometriosis. Now the next question is surgery or ART. Now again, it depends what are the associated factors. If there are any associated factors like tubal factor, male factor infertility, you will straight away go to the ART.
She's married for 3 years.
Sorry?
She's married for 3 years.
Yeah.
And now you have seen a 3 into 3 centimeter. So now what would you do in this case?
So again, if she has got a ovarian cyst, then it is most likely an advanced endometriosis, and it is 3. Usually, if it is 2 years, then I would have waited and done the conservative things and treated her like infertility. But there is an endometrioma now, and it is 3 years. So I would rather go for IVF earlier rather than delay it further. And now about whether to remove this endometrioma or not. So these days it is considered that if you are planning to go ahead with ART, you don't have to always remove. The only situations where you remove the endometrioma is if you are suspecting any malignancy, if this endometrioma is large enough to come into the way of your oocyte retrieval, or if it is causing a lot of pain. So these are few instances where you would be removing endometrioma. Otherwise, a small endometrioma these days we are not bothered with, and we go ahead with ovarian stimulation and IVF. And if at all surgery is to be done, then you can do the surgery. And there is an observation that if you give GnRH analog for 3 months prior to ART, then the results are good. So it again depends what the patient wants, how is the rest of the factors, and then you'll go ahead with the further surgery.
Narasimha Reddy sir, you would do surgery or ART?
I wouldn't do surgery if the endometrium, if this
is primary, I mean it's not recurrent.
Primarily because she wants infertility, I won't attempt any surgery in this patient. I refer the patient for the infertilologist. Then if they suggest that, if they are delaying for any other reason, they are opting for any other egg donation or something like programs, then the patient has got the severe pain, probably I may think of doing laparoscopy in this patient. Otherwise, ART is my choice.
Okay, sir. Okay, perfect. Everything is good. And now the surgery, it has gone. She has tried ART. And then they were not able to, she's not conceiving for whatever reason, because we already heard saying that there are so many things. Quality is gone. We are not only worried about the thing. The quality of the oocyte is bad, mechanical stretching and then inflammatory, and because of oxidative stress. So 6 months over, 2-3 cycles are over, then there's failed IVF 2 cycles. Then she comes back to you. Dr. Neeraj, what did you would put a scope then or no? And if you do,
she had endometrioma, right? I just missed the story.
Yeah, endometrioma, 3 into 3 centimeters. So perfectly we went in the right way.
Yes.
She has gone directly for infertility because it is a smaller one, single one, and it is 3 centimeters. So they are both Dr. Narasimha Reddy sir and Asha madam has treated for infertility. She's been taken up, everything. They tried aspiration and all that. And finally she did not conceive. 2 cycles of IVF failed. Then she's come to you.
Good reason to go for laparoscopy, yes.
Okay, so then how would you do? What is the role of, in the surgical interventions, what are the role of fertility preservation and what type of fertility preservation you would do in this case?
Now, if it is endometrioma, then it's more likely that it will not only be endometrioma, there will be some superficial peritoneal disease as well.
Yes.
And now, I know I'm talking to someone who's IVF specialist here, but as far as I know that there is significant impact of minimal and mild endometriosis also in success of spontaneous conception as well as infertility, as well as ART. So I will excise whatever visible endometriosis is present, including superficial peritoneal disease. Mostly, if it is endometrioma, tubal anatomy may also be altered and there may be some adhesions. So adhesiolysis is something which I will do. Now the question is, if it's only 3 centimeter endometrioma, I might not get a plane of cleavage to do a cystectomy properly. In the bargain, if I attempt cystectomy, I might actually cause more damage. Therefore, in those situations, maybe I'll just drain and coagulate, although that's not my preferred technique. But if there's no plane, I would rather not damage the ovarian follicles and cortex and just do drainage with coagulation. If there's a good plane and if it's anything more than 4 or 5 centimeters, I'll do a cystectomy and try to restore the anatomy as much as possible. If it's something which I feel the tubes are completely damaged, and if it's something which is hydrosalpinx, which is going to affect the infertility treatment, I might talk to the infertility consultant who must have referred the patient to see if they want me clip the tubes or remove the tubes to increase the success of IVF treatment subsequently.
Dr. Garudalakshmi, any other take on the surgical output?
Yeah, the precise dissection plane of cleavage is very important and less coagulation. And in this case, I need to tell if it is 3 centimeters, just you can do aspiration and coagulation. Yeah, before IVF.
Then there is a higher chances of recurrence. So are you ready to do that? Because it's going to come back. Sir, Dr. Narasimha Reddy, sir.
Yeah, I'll counsel the patient, because after 2 failures of IVF, what's their plan actually? She is trying to conceive with her own eggs, or is she opting for the donor eggs? The question comes. If they are for the donor eggs, then probably I may go for the extensive surgery, because I don't want to leave any of the endometrioma. Suppose she wants to go for her own follicles, probably I may go for the conservative cystectomy, like modified some amount of ovarian tissue or the endometriotic cyst may be left out at the hilum.
Right.
I may not coagulate so extensively.
Actually, best is
only point coagulation.
Yes, sir. Dr. Asha.
And in this scenario, I will always use vasopressin.
Yes, sir. Perfect. Sir, Dr. Asha.
Levels, check the AMH levels, and if possible, because you are going to do surgery, then go ahead with cystectomy. Yes. But and another thing, if this patient, because you are doing it after the IVF has failed and everything, so another good idea would be that first you stimulate the patients and do the oocyte retrieval and freeze the embryos. Then do a surgery, a radical surgery, proper surgery, and then you can transfer the frozen embryos once that toxicity has gone down, because a few of our cases it has happened like this. The implantation wouldn't occur and anything, and severe pain, deep infiltrating endometriosis. So what we did is we retrieved the oocytes, made the embryos and froze them, and then once everything settled down, then we transferred, and the pregnancy progressed beautifully. So I think
all of you actually, you gave the perfect answers, but I think we just added, I have to just get one point from all of you. So fertility preservation is the thing. Before you take any patient for any surgery, you have to understand invasive surgery, however best you do, even with vasopressin, at least some amount of ovarian tissue will be lost. So premature ovarian failure is seen in 23%. Too much surgery will lead to less ovarian reserve. Too little surgery will lead to recurrence. So current methods of fertility preservation is, first is a combined surgical technique which we spoke about. That is the ablation and combined technique of ablation and cystectomy. Or the next is vasopressin technique. Next is the aspiration and methotrexate technique. Or the next one would be the putting this gel inside. Next, with the auto transplantation of cryopreserved, freshly healthy, like I said, post hysterectomy, if you have, you can take out the ovary itself, freeze it and put it under the arm and then use it. Or cryopreservation of oocytes or embryos, like Dr. Asha told. So we have to talk to them about it and then decide for it. So this is what I wanted to tell about fertility preservation is the most important thing which we have to talk about before. Case number 4, Dr. Garudalakshmi, on to you. 32-year-old, married for 7 years, anxious to conceive again. And she had one abortion 7 weeks, 7 weeks and 5 years ago. Now again, surgical history, she had an endometrioma surgery done 3 years ago. There the tubes are perfectly normal, endometrioma, and medical history, she has hypothyroid, other than that nothing. Now it is 4 into 4 centimeter. CA125 is there and she's having dysmenorrhea, but she also wants to continue and she has a recurrent endometriomas.
No,
So what to do, what not to do, when to do, when not to do.
so by history and by examination and also by ultrasound, if it is doesn't look like a malignancy, recurrent surgery is more problematic. It causes more decrease in ovarian reserve. So ideally, you can go directly into the ART.
Right. So, okay, I'll come to that. This is the points which we have been talking about before. In infertility, what to do? Role of hormonal treatment in infertility to suppress, like combine, is not at all effort. It's ablation plus adhesiolisis we should do in mild, but moderate to severe level is uncertain. In these cases, you can just send them to IVF, like Dr. Garuda just said. And ovarian endometriomas, it has to be cystectomy and nothing else. Post-operative, no. So, Dr. Garuda actually already told before that IUI, yes, it is mild, it is good. IVF is the treatment nowadays most of them opt for. Pre-IVF, ovarian cystectomy, if it's more than 4 centimeters, GnRH agonist, Dr. Asha has already told. After the thing, before IVF, that the level of the increases the rate of pregnancy. So when not to do, when to do, this is the question. Fears of surgery, can it alter the ovarian function? Criteria for non-removal. Bilateral cysts, don't remove it. History of past surgery, don't go for surgery. Altered ovarian reserve, don't go for surgery. Send them to Dr. Asha or any IVF specialist. Exceptions is if there is pain, hydrosalpinges, very large, rapid growth. Anything else you want to add, Dr. Narasimha Reddy, sir?
Yeah, whenever it is large, usually I'll go for it. If it is rapidly enlarging, rapidly on, probably most of the, in my clinic, my experience, I have encountered 2 cases of endometrioid carcinomas.
Yes, sir. That's why rapid growth.
So first, one case I totally missed. Other case I suspected and then I stopped. Then I took the, we came out of the abdomen. Then second look, we have taken a biopsy and sent it for, because we don't have the frozen section here. Okay. We have sent it for biopsy. Then we did radical surgery in these patients. So any rapidly growing recurrent endometriomas always have to have suspicion of malignancy. Some literature says that clear cell carcinoma is also possible, but I haven't encountered any case. But endometriomas, my close friends, some of them have informed me that it is always a dangerous proposition for you to attempt an endometrioma, which is very large.
Yes, sir. Sir, pain, hydrosalpinges, very large and rapid growth.
Aspirate it and clean the whole of the cavity. Put the telescope into the cavity and look for the papillary growths or anything.
Absolutely,
probably ultrasonologists as well as the MRIs also miss it.
Yes, sir.
Even there may not be the even color Doppler, 3D, whatever the D we have it, you may miss it. But look at it. If you have got the papillary projections anywhere irregular when suspicious of malignancy, take a biopsy, come out of it, go for the second operation or the corrective surgery.
Hydroreductive surgery. Okay, thank you.
Manjula, we had one case which is a big endometriotic cyst. She is a Jan Willebrand's disease. Okay. So any patient with this problem, they may grow into a very big size.
You should
be factor deficiency.
So this is an endometrioma mimicker. It is not endometrioma. It is actually the blood which is showing the thing. That is what we are looking at. Thank you. I'm going to skip the next 5th case because we only have 5 minutes, but I want to take the 6th case definitely. And this, whom did I miss? Neeraj again, we'll come back to you.
Happy, yeah.
Yeah. Last case to you, 33-year-old woman coming to lower abdomen pain and dysuria, increasing intensity since 10 days. She has this, she's been using Dynagest, known case of endometriosis, and everything else looks alright. But ultrasound said very clearly, because she's been having bleeding during periods and pain, there is an endometriotic nodule 2 into 2 centimeter between the uterus and the bladder. They never said it is a thing, but cystoscopy was done for her, which showed it is bladder endometriosis. So this is the way, this is how it looked. My question is, would you do it yourself? Because we are the masters in endometriosis, or you legally, again, urologists are not so good in laparoscopy. Let me tell you very clearly, they're good in their telescopes and their work, but laparoscopy nowadays, younger, yes.
So the best answer to this is to play safe. I'll do it with him in the theater.
theatre.
Go and sip coffee.
Make him stand.
I'll tell him to go and sip coffee, and while I do this,
Yes.
and so it's kind of more like legally you are safe because there is a urologist present.
Right.
As a gynecologist, you're happy because you've dealt with the endometriosis.
Right.
The
And
only thing here I would do, which we have done is take the bladder nodule out. It is telling. I mean, you don't need it's no confusion in the diagnosis. It is bladder endometriosis.
right.
So once you remove the nodule, once you excise the bladder endometriosis, the only key here, which I'm sure everyone knows, is making sure that your ureteric orifices are seen before you actually start closing the bladder. But
Right.
from looking at the picture here, I don't think ureteric orifices will be an issue. But you should always make sure before closing the bladder that you are away from ureteric orifices and close it in 1 layer or 2 layers. I would do it in 2 layers and leave a catheter for at least 10 days, and that should be the answer for the problem.
Right. My question again, continuation. Would you use barbed sutures in these times of barbed or no?
I won't use, but there's no problem using it.
Yeah, literature says you can use it.
You can
That's
use it.
what I want them to know. Second, would you be conservative here or you would be more aggressive because it is endometriosis and it is an extragenital one?
So sorry, what was that?
Would you be very nearer or you would go just like how you treat the cancer, like 2 centimeter margin, or you would be more?
See, endometriosis is a field change disease, we know. It is not focal.
Yes.
So wherever you see endometriosis, around it, there will be some microscopic deposits which you will not be seeing.
So you would
But
be
again,
more,
common sense will prevail. You have to make sure that you're not going to excise a whole lot of bladder just because you're thinking that there is endometriosis. So
but then it will recur again.
yeah, if it is peritoneum, then I would go beyond the margin. If it's this nodule, yes, I'll go not 2 centimeters, but maybe half or 1 centimeter around it, but not 2 centimeters definitely.
Perfect. See the point, one thing we have to remember, most of the time bladder endometriosis does not involve the ureters that in this place. I mean, when I say bladder, not the ureteric endometriosis, the reason being that the base is the one which is adherent to the lower cervix and the LUS. So here you will not see. And then you have to go open properly, look at the Foley's catheter, like how Dr. Neeraj said, look at both the orifices, then in either 1 layer, either continuous or interrupted, no problem. You use through 2030 Vicryl, or you want to use barb, you can use that also. So you decide what you want to use it and then come please, but don't forget to keep the catheter for 10 to 14 days depending on your things. People also say 7 days is enough. But I think it's always safer when you're keeping it for 7 days, 10 days should not matter. So leave it for 10 days. And then one more extra question before I finish this panel discussion is, after this, we usually, when we do cystectomy, you are gelifying with the nerve supply there. So you would have urgency. So as a routine, would you put any Darilong or anything like that for her? If so, for how many months?
I mean, we've done this, but we've not put on Darilong or any other medication. Fortunately, we didn't have any problems. It's only 10 days. And on both the occasions, I did speak to the urologist and they said, don't worry, if it's only 10 days, we would not bother.
Nothing to do with the catheter.
I did not put it.
I wanted to add something.
Catheter, yes.
No, nothing to do with catheter. Just because we have cut we did a...
No, I know. Yeah, I understand what you're saying. But even then, the advice was don't give.
It becomes a smaller bladder. And it becomes neurogenic little.
Yeah.
So anything else we use, I just wanted to add it as a point. We give them darifenacin or solifenacin or OABF, whatever we want to use for 2 months, and really patient post-operative compliance, and they're very happy. Otherwise, they would be having this, very fast urge not incontinence, but urge to go very fast, and their regular activities would be affected. So I think for any endometriosis cases or anything, this is the last slide, which I want to stop on time, which I promised. We still have 2 minutes. So sticking to the microsurgical principles, avoiding all these things, I always tell least use of energy sources and sticking to microsurgical prevention principles and use of adhesion prevention techniques always go a long way. Thank you all for being a wonderful panelist. And thank you, Dr. Asha, Dr. Neeraj, Dr. Garudalakshmi, Dr. Narasimha Reddy, sir, for telling us and answering almost every stupid question which I asked.
Thank you. It was very well conducted.
Thank you for being such a good moderator. And I would like to thank Dr. Vindhya and Dr. Archana for giving this opportunity. And I would like to greet Dr. Shanta for being here. Thank you so much. It has been so nice being with you all at Hyderabad. Lovely. Thank you.
Madam, good luck to you.
Hi, Asha.
Madam Asha, madam, it's a good luck to you, madam.
I know. All the best, Dr. Asha. I'm sure. To you.
So,
Hi,
hello.
Thank you, Mandala Garu.
Good evening, everyone.
Hello, good evening, Dr. Shanta.
Good evening. Hi, Asha. Welcome to Hyderabad. I had actually gone to Ludhiana, then Delhi, and now just returned to Hyderabad. That's why I got a bit late. Yes. So it's nice to see you in Hyderabad. And we are all looking forward to actually visiting Indore as soon as this.
So should hire a flight, chartered flight, madam.
We will
Should have a chartered flight for you.
Yes, sir. For all of you, not for me. Okay. Definitely.
Because you are going all around India.
I'm looking forward for the AICOG in Indore, where all of you should be there to.
Let's hope that we are going to have it.
Yes,
the COVID will go.
Yeah, why not? We will have
it. Is getting a little delayed. We are delaying it, and then
yes,
we will be.
Shanta Madam will be taking over there, no? So it's very important that we do it very well.
Yes. Yeah. Thank you, and yes, Manju and everyone, Neeraj and Narasimha Reddy for us, sir. For a change, I'm seeing you a little relaxed. Nice to see you in a relaxed mode. Right now. Yes. Very good. Please take care.
Thank you, madam. Thank you, one and all.
Okay, thank you.
Thanks a lot.
Thank you, sir.
Thank you, Manju, for making it so interesting, and thanks all the panelists for your participation. Actually, your enthusiastic participation. Thank you.
Thank you, Dr. Vindya.
Everyone is all the faculty are in a very relaxed mode. Nice to see all of you in a very relaxed mode. Because in the evening, no, I think a pandemic has by default given a lot of rest, much needed rest also to some seniors.
For all of us.
Shall we go to the next topic,
Yes, sir.
Archana?
Yes, sir. So now we are coming to the most awaited topic, stump. We are going to ask the question to expert and they are going to answer. So feel free for putting it in chat box. Now we welcome our guest, who is none other than Anu Acharya. She is IIT alumni, passed out with master's degree from US, and she is an entrepreneur and a CEO of Map My Genome. She has got multiple awards: Women Entrepreneur of the Year Award, G Business October 2019, Special Recognition Leaders category by Indian Express, and Pride of Telangana Award 2018. She introduced the personal genomics in India with the launch of Genome Factory in 2013. So, welcome, Dr. Anu Acharya. Please start. Many questions are there. Most important is why the test should be done. Should we get it done or not? When? Which test? Where? How much? When? All these questions are going to be answered by her. And feel free, please, audience, to put all the questions in chat box. They will be answered by her. Welcome, Dr. Anu Acharya.
Thank you, Dr. Archana and Dr. Vidya. It's a pleasure to meet all of you on a virtual platform. I think today, while majority of the time, I think maybe people associate us with doing genome patri. For the last 3 months, I think we've been doing a lot of COVID testing as well. And I think that's something that's on everybody's mind. And while all of you might know most of the things that I'm talking about, I think it will be helpful to basically go through some of the questions that have been asked, but also quickly at least run through some of the couple of slides that I have prepared. So what I thought I would talk about mostly is about RT-PCR, a little bit on antigen and antibody testing, and look at the questions that was asked. And then if there is any time left, I would like to introduce a little bit about genome patri immunity. So when you look at the kind of testing available, I think one is to look for the antigen or the virus that we are looking at. The most common one is the RT-PCR, where we are looking at the virus by looking for its RNA. The other that we might have also seen is the LAMP method, which is actually a very easy method to be able to do it. It can be done without much equipment at all, but it's still not yet come to a point where the accuracy of the test is fully validated. And then there are CRISPR assays. I think CSIR and a few others have developed that, and you can use, it can save some amount of time, but not necessarily all of it. The other thing that has become extremely popular is the antigen testing, which is on a strip-like thing where you're taking a nasal swab and you're putting it on a little pregnancy strip. It has its good and bad things because testing, while fast result, is also 50% or so sensitivity. It's a little bit not very useful, especially if you're trying to understand if you don't have COVID. And then there are PCR-based methods which can be done quickly on more on a point-of-care basis, the ones that Abbott and Bosch have come up with. So these are the kind of testing that we are seeing where you're looking for an antigen. And then the other is the antibody testing that you're trying to find out if the virus was ever there. So you're trying to find if there were antibodies that a person develops based on whether the person had COVID at some point or not. And the third type, and I think a very popular way, at least in the hospital setting, is to look at CT scans, to look at the infection spread and what's happening with the respiratory system functionality. Sometimes I think it might be useful to have a combination of the two, especially when it's harder to diagnose. So when you look at RT-PCR testing, you can do it with either a nasal or an oral swab. And while at-home sampling is possible in the US, we are not yet there in India. We are currently trying out a saliva-based test, and if that works, we will see if we can take it further. So in an RT-PCR, you're basically looking at primers and probes. You're looking at whether there is a fluorescent dye and a quencher, and there are mustamics and there are enzymes that will start the reaction. And basically, it was principle of going to high temperature and low temperature, and the number of times it goes through the cycles is what we popularly call as the CT value. And the CT value is what everybody is now looks for when they are looking at whether this person has a high viral load or not. Well, sometimes that can be a little misleading. It is a good indicator when you see that somebody has maybe a very high CT value, could be at the early stages of the infection, and you can actually trace it back towards the end of that. So this is when you look at it from a genomics point of view, you basically start saying that there are many times that you might have heard of that some genes are confirmatory, some are not. And essentially, if you look at the whole genome of the virus, it's 29,903. You can see it over here. And these are the different parts of the genomes that are there. The ones that we typically use for confirmation would be the N and the RDRP. There are some parts of the ORF also that some people have used for confirmation, but E gene, for instance, has been used mostly for screening. And these letters, E, S, and all are basically the spike protein, the envelope, and so on, the nucleocapsid, and so on. When you look at, can it be possible that there are accuracy issues in RT-PCR? While it is the gold standard, there are possibilities that there might be, challenges, and some of it could be in how we design the assay. It could be because of low viral load. It could be because of ability of the sample that was collected, how the sample was, whether someone took the swab properly or not, and how it was collected and transported. So if you're using a regular VTM, for instance, it is still live virus, and then when it comes to the lab, there's a possibility of infecting the lab personnel. Versus if you use an inactivated medium that allows it to be safer and keep the RNA stable, I think that's an easier way to be able to do that. And clearly, I think there are RNA extraction and PCR setups, as well as what level of threshold that one uses to cut off the positive and the negative. Now, I don't think we need to understand on what makes it worse, but there are many different comorbid conditions that make our condition worse. When you look at the antigen testing, we typically use a nasopharyngeal swab, and the sensitivity according to ICMR has been between 50.6 and 84%, which means that it is quite not very useful from perspective of actually understanding if a negative is correct, because you need to actually couple it along with the RT-PCR. So you could use it in a hospital setting to quickly identify positives, but it has to be accompanied with RT-PCR for it to be meaningful. Then when you look at serology testing, you basically have different types of tests that are available. I think one that is a popular one now to understand if somebody has the neutralizing antibodies, can see if they have actual functional antibodies to the virus. The other, for instance, your Abbott's and others have come up with a CLIA-based assay, which will show that it is whether the person has antibodies to the pathogen, that you're basically looking at it from a fluorescent signal. And then there are the regular ELISAs, whether it's the direct or the indirect. And then the last one is the rapid antibody test, where you can put a quick drop of your pinprick of your blood and see if you have IgG and IgM. So what is the, when you look at it from a schematic, this is a typical infection time. You look at approximately 20 days of infection time. And you can see that IgM typically would start after about 7 or 8 days. IgG typically about 14 days or so. Of course, this is not a set standard. It can be different things for different people. But at least based on what we have seen of quite a large number of samples that we have analyzed, that's approximately seems to actually agree to what we are seeing over there as well. So these are some of the questions that I was given, that when you look at it, that we have come across as asymptomatic versus symptomatic patient, is there a difference in terms of when you would want to test? And because the incubation time is typically 5 or 6 days, sometimes it can be as high as 14. I think it is safe enough to be able to test after about 5 or 6 days. So that would typically be what you would look at. The other question is, when would you give a blood sample for IgG and IgM? Like I showed, typical timelines would be 7 and 14 days. But again, it depends. We have seen cases where someone didn't develop IgG even after a month, and they still had IgM after about 30 days, but that's not usual. That's more an exception. Another question was on private labs and antigen testing. Currently, we are not allowed to have asked the department, and only government labs are allowed to do that. But hopefully, they might allow us. I think in Den a few they are in private labs as well. So one question on when someone gives sample, if there was a bleed in the nose, is it possible to still test? It is possible to actually test that particular sample. So you can test it with even with that blood contamination. But the second is also that you can also take a oral swab and hopefully soon a saliva swab if that becomes a challenge. Another question is, again, similar, whether if there are symptoms like fever, cough, and others, after how many days? I think if you already have symptoms, it might be best to test straight away. And then there was one question on, where to look for these options. Who does what? I think there is a website by the Telangana government called the COVID-19 website, and it lists out all the government labs as well as the private labs, and it tells who does CBNAT, who does RT-PCR, and so on. Also, if you just do a Google search and say labs around me, I think it gives you a whole list of labs and what they're allowed to do. Then I think another question somebody asked was that government labs, RT-PCR takes time. What to do meanwhile? I think today the time for results for RT-PCR has reduced significantly. I think most people can give results in a few hours. If it's in the morning, you get the result by evening. But otherwise, there is obviously the antigen test if even that much time is not acceptable. But as I said, antigen is not something that you can take as a gold standard. If it is something that you want to quickly identify for somebody who's highly symptomatic, it might be a good option to do. How do we test for asymptomatic? Sure. Hello? Yeah, did someone ask a question? Or?
You can continue, Anu. There was some disturbance.
Go ahead. Yeah, sure. Someone asked if, can you test for an asymptomatic people? How do you test for that? And I think the simplest way is to do an RT-PCR to test for that. And again, when do you retest for somebody once someone has been positive? While we have seen the earliest signs of it going away in about 14, 15 days. It can also be less. If it is less, it's typically because you caught the infection late. But normally we've seen, because we do testing for our employees every week, we've been able to find people at the start of the infection, pretty much typically before the cycle starts. And then when we've measured, it's typically 3 to 4 weeks on an average. So I would say that the testing for positives, if you have caught it a little bit late, then 14 days is a very good time. If it is a little bit later, then 21 days gives you a good chance of it becoming negative. But sometimes if you have caught it really early like we do, then it's possible that it can take about a month for it to go from a CT value of about 37, 38 or 39 to all the way back to getting back to negative. The other question was, is there a time difference in RT-PCR to become negative post-infection for asymptomatic, mild, moderate, severe cases? Unfortunately, based on the data we have, it has not been the case. We've seen some people with asymptomatic also having a very long infectious cycle and others who have not. So it is not really easy to be able to make out that difference. The shortest time, like I said, can be a week, but it's because they've got the infection later. And the role of CT scan in asymptomatic RT-PCR positive patients is very useful, because sometimes in combination can give you good results. Even if you get negative in RT-PCR, but you have a CT scan, I think it gives you some amount of information, because you still want to look at who has a very high the infection in the lung. But otherwise, sometimes putting these two together, clinical parameters, is always a helpful. If antibody tests, if they don't want to do RT-PCR, like I said, I think at least a minimum of 7 to 10 days for you to at least even see if IgM is developed, and about 14 days for IgG to develop. And the immunity after infection, I think it is still a fair game, but most people have said that the reinfection rates are still very, very low. But we have seen, there have been people who have said that they have seen pre-infections. It could possibly be that sometimes people are not, they've been tested negative and they were actually still positive and they test positive again. So it's a possibility if they've very quickly been found the negative and they left. So it could be a false negative, but it could also be something that, because at least the documented evidence still points that we are not seeing reinfection, and we are also closely monitoring people that we are getting to see if there's a possibility of reinfection, and if that is the case. So that's about, I would be happy if there are additional questions, and while I do have other slides on many other things, I'll just email that presentation as well.
One question, Anu, is what do you think about random testing in the community? Does it help?
I think it does. In fact, I've been involved with a few projects. One in Karnataka, where we did the whole project. In fact, we're just getting close to understanding that in the entire state of Karnataka, where we did both. We basically used a very statistically sound sampling method to do a community-wide testing. But we did both antibody, RT-PCR, as well as the rapid antibody. And it was interesting because it basically shows where the past infection clusters are there. And it also shows where the infection is currently spreading. So it is very valuable to be able to do that, but it has to be done with a sound mind in terms of how you want to do that sampling. So whether you're doing it for research or identifying clusters perspective, or whether you're trying to do it for very quickly doing that. And if you want to do that quickly, let's say over the state of Telangana, then it should be done up in a very few days all over the state. Then I think it becomes a lot more helpful, because sometimes when it stretches over a month or 2 months, I think the infections can be very different. The rates can be very different at different points of time. But we have done also some of the people, investigators along with me, we have done projects in Mumbai, the seroprevalence study. They've done one in others. While sometimes I think what data is coming out in the media is not necessarily the right kind of data that is coming out, I think those are helpful to at least understand if the community at least has been exposed and what are the levels that we're seeing.
Someone wants to know the chance of false positives and false negatives.
Correct. So I think I was basically, I mentioned that.
I think you mentioned they must have missed it. Yeah.
Correct. Yeah. Yeah, I know. I was trying to go through all these very quickly. But basically, I think if you're seeing false positives in a RT-PCR, it is probably because of contamination. And that would mean that you have a poor hygiene in the lab in many ways. So that would be the reason that they're false positive. You can get a false negative. For instance, if your threshold is at 35, we would still give you till 38 or 39 as a threshold. Then if you cut it off at 32 or 33, then you obviously will find a negative faster than otherwise. That could be one. But the reason to get a negative when you are a positive is in the way people actually collect the samples. So if you don't have trained technicians who are collecting the samples, then it becomes a challenge because you have not collected enough material for it to actually detect it. So I would say those would be primarily that. In terms of the assay itself, I'm assuming that at least most of the assays that ICMR has approved in terms of the kits are confirmatory genes. So for instance, if they have used only a screening assay, then it could be a problem. So you need to make sure that the assay that is designed has at least an N gene as well as a RDR or an RDRP and so on. Then I think you have been able to get the right answer over there. But if all the things are correct, if the hygiene levels are correct, if the technicians are doing a good job, if you are able to make sure that the sample is transported to your lab safely, then I think it is a gold standard and typically you should not get errors and you'll be able to catch it very early on, sometimes even before you'll start seeing, and most of the time you'll see it before you actually can get the symptoms.
Anyone has a question? I have one, but I don't want to ask you again. I think if anyone has, let them ask, otherwise I'll have one.
Vindhya, I think there is one question again, that how do they get to know if they're reinfected? I think she has answered, but once Anu may... When somebody has a doubt, how do I know if I get reinfected? I think you have to do a RT-PCR again.
Correct. So you have to do RT-PCR. Yeah, sometimes I think there's it's a false negative in between a cycle, and I think that's why people think they're getting reinfected many times. Yeah. But I think I would say that if they have done if they've done an RT-PCR and they got a negative once, I think it is probably a safe idea if it is happening within 7 days or 10 days to actually get it reconfirmed by another lab, because I don't think it's cleared up, and therefore the second time they do it, it looks like they've been reinfected, but actually it is just the cycle that is going on. And sometimes the virus might last for a couple of months as well. So it is a dead virus, but it's still there. So I interrupted someone in between.
When can people go back to work? Should they do a testing before negative testing to go back to work?
Ideally, yes. But otherwise, if they wear a mask after 3 weeks, then I think
mask is a definite thing. We have to live with it, but still.
I would say at least give it 3 weeks before people come back to work. So
should we get a testing done before we go?
Ideally, yes. I would say it's a good idea to get. In fact, I think people more than me, sometimes I tell people it's okay after it's been a month, no need to get tested, but people want to see the negative report. So I would say that it's a good thing. Even in our own employees, we've seen that even after they have been negative twice, they still want to go through the whole testing process again. Because I think once someone's been infected, they are always a little bit worried. But unfortunately, because of some news items that showed that a lot of reinfection is happening, I think that's why people are more scared. But I would say that as long as people are maintaining a mask hygiene and all of that, I think after 3 weeks of COVID, I think you should be okay. But for own satisfaction, it's a good idea to get the negative test.
But Anu, I feel for the healthcare workers, it is mandatory better they get them tested, because tomorrow we don't know some medico-legal implications. So I would advise all healthcare workers to get a negative test before the rejoin work. It's very important. Now we don't know, but few months down the line, you don't know the medical legal implications. Suddenly somebody may, so it's always better that they have that negative report before they join back to work, especially doctors and healthcare workers.
In fact, if it is just after 2 weeks, like I said, I prefer to get 2 tests done, because in case there's a mistake and you have still active virus and you expose yourself again to the virus, it's probably worse for them. So it's, at least for doctors, I think it is because you still may be in contact with people who have the virus. So it's always a better thing to do. I agree.
Any more questions?
There is one more question in the chat box, Vindhya. Somebody had a doubt if the patient had an CORAD 5 and becomes CORAD 3 in 20 days later, when do they do elective surgeries for those RT-PCR negative patients who had only the CT changes?
That I will not be able to answer, I think.
No, that is the period of infection. If the RT-PCR is negative, but you've got CT changes, what is the ideal time to do they may have been posted for some elective surgeries.
Retesting.
So retesting. So not retesting. It was already RT-PCR negative, but there were CT changes. So probably, as you told, 14 days is the time for the infection to settle down. So emergency maybe 2 weeks. Otherwise, probably 3 weeks. No, as you told, because 3 weeks is the ideal.
Correct. I would say at least 3 weeks.
3 weeks, unless it's an emergency and you can't defer.
And it needs to be done. Correct.
I think everything is answered.
Okay.
No,
I thought I'll just tell that the other thing that we've been studying, which is exciting and not necessarily on the COVID-19 directly in terms of understanding infection, is to see if you're looking at certain kinds of things, whether it is the drugs, whether it's comorbidities, whether you're looking at cytokine and others. I think one is a genetic test can also help you in understanding that. So I thought at least I'll just mention that, and I'm happy to send the presentation to whoever is interested.
But does the genes have something to do with the severity of the disease one gets?
Absolutely, because I think they play a very important part in how it is how the pathogenesis is happening. So we are seeing that there's a lot of differences in people's genetic makeup and how their severity, whether they get a cytokine storm, whether they are whether they are actually going to be responding to certain medications or not. So I think that's one of the things. For instance, we look at the ACE2 gene, we look at certain other things for the cytokine storm and a few other things. So those are the areas that I feel are interesting, and we've started to see a lot of interest from a consumer point of view. So at least if from a medical point of view, if the doctors are interested, I think it's helpful for them to also see if these kind of things can be done. So we are looking at like the drug responses, then the nutrient stores, the zinc. We are recommending, for instance, most medical doctors would recommend zinc, vitamin C, D, and so on. You can at least look and see whether they are predisposed to having low levels of that as well. As well as, genetics can be used in many different things, but I thought, at least I'll give a flavor of what we are doing. Sorry, you're saying something, Dr. Neeraj.
I wanted to know, we've been hearing and reading about this low virulence strain and high virulence strain. We've been lucky that we've got low virulence strain. Is it true? Is there some scientific evidence to back this theory up that you have a low virulence strain in India?
No, so in fact, we've been analyzing the genomes of so far what we got. Only now we've started to see slightly different strains that are coming in. But till very recently, we are seeing that it's the same strain that is there. So there was no real virulence level of the virus itself. In fact, we are trying to understand and see if more are there. I think the new, there is I'm trying to remember the name, the nextstrain.org, that actually shows you where all the strains are coming from. And if you zoom in on that, you'll see that India is not really any different from the other parts of the world. We got, the original Wuhan virus, we got, some of it came, so it is not necessarily that. I think it has to do a lot with our comorbidities, it has to do with our age, it has to do with, how we are what our genetic makeup is.
Right.
But understanding the viral genome is also exciting. So we've started to now see a little divergence in that, but it's still not affecting it too much, both based on how you're going to diagnose the disease and also in terms of, so you'll be looking at if there are mutations, and we have found some mutations, but sometimes they are not necessarily at the places that are going to affect, what happens to the diseases at all. But there are many initiatives going on now across the globe to study that, and also the study the host genetics. So one is to study whether the genome has been mutating. The second is that is there differences in different populations. So there is one where I'm part of, it's called the Host Genetics Initiative. It's a worldwide effort to understand if different populations react differently because of their genetic makeup and not because of the virus gene.
Right. Thank you.
Sure.
Thank you, Anu.
Sure, thank you.
Thanks a lot for coming into our webinar, and we had so many questions. So I think they will ask you individually later on. They may bother you.
Not at all. Anytime, I think, please feel free to share my contact details with anyone who needs. I'd be happy to. Thank you.
Shall we go to the next talk?
Yeah, thank you, Dr. Anu Acharya. Now we are having a discussion on massive blood transfusion. We had discussed about the postpartum hemorrhage management in the previous seminar, but we still have to have many questions to be answered regarding massive blood transfusion, which we as an obstetrician find as emergency where nobody is there to guide us. So direct lessons from our expert today, Dr. Sudha Ranganathan, who has done her MBBS from Tamil Nadu, and she has done a specialization from immunohematology from KEM Hospital, Mumbai, worked as transfusion medicine expert at Tata Memorial Hospital, and presently she is working at Apollo Hospital as transfusion medicine consultant. Welcome, Dr. Sudha. And we are having many queries. So in between also we'll be asking few. And please do answer all of our worries and queries which are related to massive blood transfusion.
Even about plasma therapy. Yeah.
I will try my
We are doing a lot in her hospital, Apollo, so she should be the expert to clear all our
try
doubts.
my best to answer queries. I think, good evening, ladies and gentlemen. Thank you very much, Dr. India Madam, for giving me this opportunity. And I think the Society of Obstetrics is very robust. I must say that starting from endometriosis, you jumped to COVID, and now the blood transfusions, wide, varied topics. And I think all of you are having a lot of time now for this. And so let me start this on a very light note. It's always presumed that if you are a very skillful surgeon, you give very less blood transfusions. At least in the UK, they believe that you give less transfusions, that means you are a very good surgeon. So that's a very light note. So yeah, this is visible, isn't it? The slides are visible?
Yes, visible.
Yeah. So there's a long association of blood with obstetrics, I would say. In fact, blood transfusions were born from obstetrics. I'm sure
your audio is not getting disturbed in between, Sudha.
So the very first blood transfusion from human to human was done by obstetrician James Blundell in 1818, very much before the blood groups were actually discovered. In fact, that was an exercise he did to save the life of a patient who had hemorrhage soon after she delivered her baby. He took out some blood from the husband and he pushed it into her vein, and he saved her life. And this article was published in 1829 under the in the issue of the Lancet, where James Blundell shared his experiences with whole blood transfusion. He addressed the benefits of rapid execution of blood to prevent bleeding, and also he quoted some importance of avoiding air intake, now what we call the air embolism in the veins, And also he commented on the incompatibility of heterologous donors. All this much before the discovery of blood groups. Blood groups were discovered later on by Karl Landsteiner in 1901, and since then there have been tremendous technological advances like in collection and storing of blood, separation of blood into components, and the concept of component therapy had come previously for the past 20 to 25 years. And now we stand here on evidence-based transfusion practice. You want a unit of blood for your patient, you must see what indication it fits in. So that's how we start the practice of transfusion practice these days. It's really surprising and rather shocking to note that even now, in the era where we have conquered so many things, that's what we believe. In the US itself, there is a 11% maternal deaths were reported to be because of the postpartum hemorrhage. And what we as healthcare workers must note that 54 to 93% of these deaths are all preventable. So we must look into the reasons why there is preventable reasons for postpartum hemorrhage. The WHO data is almost the same. Severe bleeding due to childbirth has been the first and foremost problems for all maternal deaths. And this is a chart familiar to all surgeons, whether it's obstetric bleed or a traumatic bleed. This chart is the same for everyone. Blood loss is classified as 1 to 4, and depending on the blood volume that is lost. Like if somebody loses less than 15% of blood volume, it's classified as 1. And if it's more than that, up to 30%, it's 2, and so on and so forth. When we were residents way back in 20 years before, we used to measure the soaked gauze pieces. I don't know how you measure right now. That was all subjective. Somebody would say it is 10% loss. The anesthetist would say, no, it's 20%. I don't know how you are the best judge now. Is there any objective blood loss estimation? I really do not know. But this chart has been quite useful in the ORs to start the blood transfusions. I don't have to tell this, but just to complete the talk on massive obstetric hemorrhage, the reasons are antepartum hemorrhage, PPH, ruptured ectopic, any unexpected road traffic accident, when you're doing a highly, operating a highly vascular area, and any prolonged surgery, all lead to, they are more prone to have a massive hemorrhage. So the priorities of treatment during such instances would be first to restore the volume of the patient by giving crystalloids and colloids, maintenance of tissue perfusion of oxygen, achieving hemostasis. That's foremost. Without that, it's difficult to maintain the hemostasis in the patient without seeing what is the reason for the bleeding, and correcting the coagulopathy by different blood components is what would be highlighted now. And I must stress on the fact that if the patient bleeds for more than 15% of the blood volume, one must start transfusing the patient with blood. So coming to exactly what is a massive blood loss or massive blood transfusion? Replacement of one blood volume within 24 hours, or 50% of blood volume that is replaced within 4 hours, or more than 150 ml per minute loss of blood is all termed massive blood loss, and hence the same thing for a massive blood transfusion. So at this time, what one has to do is activation of a massive transfusion protocol. It's called MTP. Please read it as massive transfusion protocol and not medical termination of pregnancy. And this has been shown to significantly improve the survival rate of the patient. If you are working in a hospital where you have blood bank facilities and you have a robust transfusion meeting and you have a team to look after this, you're very lucky. So you have to just put it in place and activate that system. And if you do not have a blood bank in your premises, you should call for blood in advance, if you are expecting any kind of massive bleeding. The key to any good outcome in such patients is picking up the phone, communicating with the people involved. So it's basically a teamwork. Early and prompt action and good communication between all clinical specialties. When Dr. Archana was communicating to me,
Hello. Might I request either Dr. Vindhya or Dr. Archana to take some audience questions while we sort out this issue?
I think there's something, there's power failure with Sudha at the other end.
Some connection problem is going on, ma'am. There are Manjula madam is there now at present, or any of the panelists? Can I ask few questions regarding endometriosis also in the meantime?
Yeah.
Many questions have come.
Yeah.
Yeah. So one of the question is, how long can we give LNG for adolescent girls? And if we are starting her on, second question is OC pills, how long, for how many years?
No, Archana.
Yes,
Yeah, can you hear me?
Yeah,
So what Manjula has told, you should use until she gets pregnancy, OC pills. Long term. And even Dynogest, there are studies you can use even 5 to 6 years in adolescent more than 18 years. There is no need to stop the either progesterones or LNG IUS. So she can continue. It's a very low dose.
Young girls are worried about the amenorrhea they go into.
Yeah, the current was not there and still it is not come. So I don't know how to share the video with you.
Then one of the question is, will ovulation induction drugs flare endometriosis?
No, not at all. Not at all. And especially for endometriosis, instead of clomiphene, gonadotropins are better drugs. And for minimal and mild endometriosis, first initial you try with IUI and natural conception instead of going to IVF. Only in severe endometriosis, you go for IVF. You can. And I have seen so many patients, even with severe endometriosis, that after treatment, after surgery, they'll conceive. So don't think. So give hope to the patient.
Because out of fear, they should not stop ovulation induction.
No, my own cousin only, she is previously, only they did, instead there is no laparoscopy. They did laparotomy for severe endometriosis. She conceived, she had 2 children. So give them hope. Don't go directly IVF. It is my opinion. Yeah.
Ma'am, one of the question is importance of endometrial and bone marrow stem cells in endometriosis. Is stem cell any use at present or still under research? And we may in future think about it.
No, that is whenever there is a poor ovarian reserve. So if there is complete destruction of ovary, if there is a poor ovarian reserve, then you can use stem cell or PRPs into the ovary, not for instead of going for donor egg. That is a management. Yeah. If they want their own pregnancy, their own children, own genetic children.
Regarding biomarkers, when somebody has asked about biomarkers, role of biomarkers in endometriosis.
There are at least 200 biomarkers which have been tested in endometriosis, and there's not one of them has been validated. So forget about biomarkers; they are not going to be helpful in diagnosing endometriosis. CA125 has a role. There are some clinicians who are doing it. There are some who don't do it. Those who are doing it will do it, or it will be helpful from prognostic point of view, because if it's raising again, it may tell you that the disease is either progressing or recurring. Therefore,
or it could be a malignancy. She's
yeah,
going in endometrial malignancy.
but otherwise there is no biomarker which has any validation as yet, so there's no point.
It is only for research purpose.
Yeah.
No, for clinical, these biomarkers there. So the first and foremost is you have a patients to have a history taking. So listen to her, what problem she is having. Next, second important is your clinical pelvic examination is very important. Nowadays they are not doing. Next is non-invasive ultrasound. You can diagnose. Then gold standard is laparoscopy. No, I think so. These biomarkers only for research purpose. Okay.
One question is LNG device in unmarried. Is it advisable?
Yeah, there is what they are saying, instead of original LNG IUS, they are having for adolescent to smaller size. So in Western countries, they are using who they want for both contraception and also for endometriosis. So it is advocated for adolescent girls also, LNG IUS.
There is no reason you should not use LNG IUS in unmarried women. Yes, there is a kind of reluctance from the patient's side, especially when you're doing any vaginal interventions. But when you convince them that that's probably the best treatment for her, having failed or tried other treatments, then there is absolutely no reason we cannot put LNG IUS. And once she is married, once she plans pregnancy, you can always remove it. That is an outpatient procedure anyway.
Regarding COVID testing, Dr. Anu Acharya, are you there?
I think she's left.
Because few questions are there regarding chance of being false positive.
I think she told about false positive and false negative.
Yeah, mostly all the questions have been covered in this one.
No, in the specificity of RT-PCR, COVID is very high, but the false negative will be very high as well, which means that if those are the things which she showed on the slide also, and that is what we know, it depends upon the sampling technique and how trained your personnel are, and when you test that it may come negative despite the fact that you may be infected. So sensitivity is something which is an issue, but it depends upon these multiple factors.
Yeah, false negative is almost 60%, around that much.
Yes.
But chances of false positive is very less, I feel.
False positive is less, but false negative is more.
I think it is more like pregnancy test also. If it is positive, we have to search somewhere that pregnancy may be there, unknown origin and all. Same way here, positivity, once positive, we have to think, but there may be more chances of having positive. Rather than false negative can be there, false positive chances are very less. And then
Sudha is ready with her slides.
Yeah, then we can go to Dr. Sudha.
Ask, that's what.
Yeah, I'm so sorry about this.
No.
So what I was trying to say is, first and foremost is talking to people and letting them know that, particularly the blood bank, letting them know that you want massive transfusions for a patient, and this has shown a good coordination is required. Are you able to hear me?
Yes, we are.
We can hear you.
Am I audible?
Yeah, you are
audible.
Yes. Okay, thank you. So the most important thing is to start talking to blood bank and arranging for blood, and this is the best outcome. The coordination and a good communication between all the specialties needs to be there for a good outcome for patients. The next slide, please. So several studies have shown that whenever there is active massive hemorrhage that is taking place, you need to give packed cells, fresh frozen plasma and platelets in 1:1:1 ratio. Particularly in the military wards that the US and Iraq had, there were several publications to show this, that 1:1 ratio is a very important consideration to salvage the patient whenever there is a massive hemorrhage. Next. So one important thing to remember is you need to get laboratory investigations done whenever there is a massive hemorrhage like prothrombin time, activated partial thromboplastin time, fibrinogen, fibrin degradation products, a complete blood count, arterial blood gas analysis, biochemical profile, all needs to be done. But you need to remember that you need to send the sample to the laboratory and wait for the results. Now I want to stress on the fact that there is a point of care testing available like thromboelastogram that is used in theaters like transplant theaters where patients are more prone for bleeding. So the same thing could be adopted for obstetric hemorrhage also when you're expecting the patients to bleed. You can use the thromboelastogram. It is a point of care testing. It tells you the dynamic status of the patient, why the patient is bleeding. The next slide, please. So this is just to show you the graph that you would obtain. And the next slide. You can, yeah, this is just to show you the graph which is available during the in a TEG that comes out within 10 minutes, and that too it is very, it's a point of care testing. That means you can do it in the OR. The anesthetist can do it and tell you what's going wrong in the patient, why the patient is bleeding, and depending on that, the blood components also can be given. So TEG sort of can tell you which component, whether it's FFP, whether there is a coagulopathic deficiency, then you can give FFPs. Whether there is a problem with fibrinolysis that is happening, then you can you give the next slide? Next slide also. So this is what I was trying to say. So whenever there is a problem, R time, and there are different names for that. So if there is an increased R time, then it's a coagulopathic failure. Then you need to give FFPs. Then when there is a decreased alpha angle, then you need to give cryoprecipitate. When there is a decreased MA, then again platelets need to be given. That means there is a thrombocytopenia. And then there is the fibrinolysis. You can think of tranexamic acid. Whereas in the routine laboratory tests, you won't be, you have to have a judgment based on your clinical opinion. Whereas this gives you exactly why the patient is bleeding, and you can have it in the OR itself. Next. So these are the transfusion triggers one has to maintain during massive hemorrhage. You have to maintain the patient's hemoglobin at more than 8 grams per DL. And if you know the blood group, you please transfuse the same group, keep O negative. If you do not know the blood group, then obviously you need to take an O negative. And by the time you finish 1 unit of blood, we can give you the blood group, and you can start giving the same blood group from the next unit. Next. Then the triggers for platelets, you have to maintain it above 75,000, and fibrinogen of more than 1 gram, and PTA, PTT values should be lesser than 1.5 times the normal. These are general triggers, guidelines for you to maintain the hemoglobin and platelets at levels which are comfortable for the patient to achieve hemostasis. Next. So this is a chart which shows, which guides you when to start what type of blood component. So if you see this, if the patient bleeds to lesser than 1 volume of 0.5 volumes, you can treat the patient. You can maintain the volume with colloids and crystalloids. Then comes the packed red cells. Then if it is more bleeding, then ask for FFPs and platelets. This is how one should go about treating a massive hemorrhage. Next. So I would like to explain the concept of fresh whole blood, because many surgeons and obstetricians are still stuck with this fresh whole blood concept. I don't blame, because all of us were trained like that some 20-25 years ago. I hope the recent obstetricians and postgraduates who come out know the concept of component therapy. Now, in this era, where the whole blood is rarely indicated, and that fresh is what? There is no definition for fresh. Is it 4 hours? Is it 6 hours? Or is it 24 hours? There is really no definition for a fresh whole blood. So once we take out the blood from a blood donor, what happens is the plasma factors deplete after 6 hours of collection, and the platelet viability decreases every hour after 4 hours. And as you know, the testing of donor unit has to be done for various tests like HIV, hepatitis B, HCV, etc., etc. And all that testing would take a minimum of 4 hours, even under a robust technology. And if one does an extra testing like the nucleic acid amplification testing, it takes around 24 hours for the blood unit to be ready. So there is no concept of fresh whole blood these days because of these mandatory testing is there. And in combination with the fact that the blood availability itself is a big problem. So 1 unit of blood, we can help 3 different patients. So together with all this, the indication of fresh whole blood concept is really dying down. Next. So this is to just show you the different type of blood components that exist in a blood bank. It is packed red blood cells, fresh frozen plasma, platelets, random and single donor. There are 2 types. Random platelets is the one which we collect from a normal blood donor. Single blood donor platelets is done with a cell separator. It collects a whole unit of 300 ml of platelets from a single donor. So in a massive hemorrhage, particularly in obstetrics, when you don't want to pump her with donor blood from different type of blood donors, single donor platelets would be useful for such patients. And then again, there is a component called cryoprecipitate. Next. One must remember that massive transfusions do have their set of problems. One is hypothermia, because you will be giving cold blood, refrigerated blood taken out in 5 or 6 units and just push it in the patient. But if it is cold, then patient automatically goes in for hypothermia. Operating rooms these days have what is called warming of blood. There are blood warmers, so you can use the blood warmers while giving these blood transfusion to prevent hypothermia in the patient. Then if you're giving a lot of blood without adding platelets and plasmas, patient can go into what's called consumptive coagulopathy and thrombocytopenia. That is why it's important to use the ratio of 1:1:1. Then again, decreased calcium level, because you must remember that blood has calcium and that goes and acts with citrate and causes chelation. There is a decreased calcium level in the patient's circulation. You must measure calcium levels once in 4 hours while giving the transfusions. Then again, when you're giving a huge load of volume of blood, many patients go into pulmonary insufficiency or what's called transfusion-associated cardiac overload. So you must remember all these. So you have to give the volume and the rate of blood transfusions need to be given according to the what the patient could take. Then another important complication of transfusion is disseminated intravascular coagulation, and not to forget all the problems of transfusion reactions. Next. So I would like to explain some few cases of common transfusion reactions and other cases which we had come across, and we can see one by one. That's a 25-year-old woman with hemoglobin 7 grams, and she's due for delivery in 3 weeks. So there's no way you can give her iron or anything else. So obviously, you're giving her transfusions. When you give 2 units of blood, after 1 unit of blood, she has some fever, and her vital signs were stable. Her blood pressure was okay, and the heart rate was also okay. But then she had 101. Her basal temperature was normal, and now after the transfusion of the first unit, she has 101 degrees. So obviously, this is a blood transfusion reaction. So would anybody like to comment on this, how you would go about dealing with such a case? So the next
treat her symptomatically and wait and see.
Yeah, correct. Absolutely right, doctor. Can I have the next slide? So you need to do certain measurements. Obviously, fever is a very important reaction. It could be life-threatening if you have to cross-check all the things which you have given, and samples should be sent to the blood bank for the repeat confirmation of grouping and cross-matching, and the direct antiglobulin tests to see whether they have done any mistake while collecting the sample or doing the test. So the next. So this is what we call a febrile non-hemolytic transfusion reaction. This is the most common reaction along with the allergic reaction which we come across in daily blood transfusion practice. And many patients who receive multiple blood transfusions go in for febrile non-hemolytic transfusion reaction. So why does this occur? This occurs because of HLA antibodies which are there in the patient and is acting against the donor blood. So management, as you rightly pointed out, doctor, it is because of by giving antipyretics. But please do not pre-medicate the patient. This is not at all advisable because you would be masking any reaction. So you have to wait and watch observation, documentation, and then you can, if she develops fever, then you can give the antipyretics. Next. So prevention, one important thing is now we have some technological advances. We can reduce the WBCs that are there in the donor blood, what we call liporeduction, because this type of reaction is because of the WBCs that are there in the donor blood. So we can use the reduced filters blood that can remove around 99.9% of WBCs in the donor blood. Next. So what do we learn from this case? Febrile reaction is very common along with the allergic reaction, and you can prevent this by giving a leukoreduced blood. This is a very simple type of reaction. Next. So this case I want to just put across. She's a 25 years trainee posted for LSES. She was not booked under you. So you are seeing her for the first time because of fetal distress. The obstetrician readied the OR and sample was sent for blood grouping and cross matching. And during the operation, the patient the obstetrician had to perform cesarean hysterectomy, and they next. Next slide. So no. Before this, there was one slide. Yeah, post-operative, it was very eventful. In fact, after all the massive transfusions and the cesarean hysterectomy patient had, she did not improve with all the transfusions. Patient was anemic, and spherocytes were there in the peripheral smear, platelet counts. I'm sorry, can I stop here and go to my desktop and start talking? I'm more comfortable in that. Madam?
Yeah, you can do that.
I'll just stop this because I have to see the login ID and then start again.
How much more time, Sudha, or do you want to take the questions?
Yeah, no problem. You can ask the questions because it's already 8 o'clock. No problem, madam.
Yeah, but we would...
You can decide.
Yeah. So, Archana?
Yeah.
Maybe I'll try quickly.
Yeah, first, one of the question somebody has asked, if a male donor has given a blood, so will his or blood will be used totally or plasma will be discarded? And in female, why the plasma is discarded? Any specific for it?
Yeah, a male donor
because actually I had a case. Yeah, in a male donor, there are no HLO antibodies unless, see, why the HLA antibodies develop is he has to be alloimmunized either by a transfusion or a pregnancy. These are the two reasons why anybody can get alloimmunized. So that is why the mother, a lady generally gets alloimmunized when she has pregnancies or blood transfusions. That is why her plasma contains HLA antibodies. So I will probably show you this.
One more question can we ask?
Yeah. Please.
What?
I had one.
Yeah, one question is
showing trolley, so I thought I will just share that case with you. Yeah. Yeah, this is what I was trying to tell you. This. So this is what I was trying to say, that there is some entity called a trolley, which happens in so once the FFP transfusion is given, patient developed acute breathlessness, hypertension, and oxygen saturation also dropped. And this is what is called trolley. Because of the HLA antibodies, there is a clear white lung that is developed, and there is an acute respiratory distress. And this is the main pathophysiology is the HLA antibodies in the donor plasma. So I was trying to explain that whenever the a woman gets pregnant, she is sensitized with the antigens from the fetus. So there is a development of HLA antibodies. So these HLA antibodies go and attack the host, and they develop what is called a transfusion associated acute lung injury. So this is why we do not give the plasma from multiparous women. The same reason why we don't take plasma therapy from a multiparous woman. In fact, this for this only Dr. Vindhya called me. You please explain this to our obstetric people. So many people do not know about this reaction. So that is why the plasma from multiparous women, generally we do not transfuse, we put it aside. But the same thing for a male patient, we do not do unless he is transfused. If he gives a history of blood transfusion, then there are chances that he would have developed some HLA antibodies. So should I go through the slides, or should I answer the?
one more question is there. Blood donation by siblings, and even husband is discouraged. Any specific reason?
Yes. So, I had a case for that also actually. Just go through this case so you can understand that. 65-year-old patient came for hysterectomy. So, the fear of transfusion transmitted infections always is there with patients. So, she insisted that her blood to be transfused from the sons. So, the sons gave the blood to this patient, and she went away after the surgery. She was discharged, but she came back with complaints of fever and rashes after the 15th day of surgery. So you were trying to see what happened. You were thinking of obstetrician thinks of drug reactions or any other differential diagnosis that could be done. Then when they sent for a routine hemoglobin, the hemoglobin was just 6 grams. In spite of the blood transfusion during the surgery, the WBCs were very low, 1000, and platelet counts were also low. So LFT was raised. So the obstetrician admitted the patient, referred it to a hematologist. So a bone marrow biopsy was done, and they found that it's a complete bone marrow aplasia. But patient couldn't survive in spite of treatment. and she died because of neutropenic sepsis. So this is what we call the transfusion associated GVHD. So why this occurs is, even in immunocompetent patients, this is known after bone marrow transplants or any other transplants, but in immunocompetent individuals, this occurs because the kith and kin, the siblings and the sons, we all share one HLA haplotype with the mother or the father. So this is why there is a graft versus host disease. It rejects the donor blood. So this is what we call the TAGVHD, and it is very well documented. Patient presents with skin rashes and basically diarrhea, liver derangement, bone marrow aplasia, and unfortunately there is no treatment for this. So most of the patients have died because of this GVHD. So that is why we discourage the same blood being given. But we know many patients are very paranoid about transfusion infections, particularly HIV. So what there is a technique to prevent this. Like we can do what is called irradiation on the blood. So after the irradiation of blood, you can see there is a change. Blood not irradiated, then it becomes irradiated. Then this can be safely transfused to patients without having the GVHD problem. So this is the very reason why the siblings are not, blood transfusions should not be given for close relatives.
We can rush up the slides because time is shooting up.
Yeah. So I just thought that administration of blood, I don't know if people are important, is important. Then take home message, I will wind up the last slide. Massive transfusions requires a good coordination between the theatre and the blood bank team. And if patients start bleeding to more than 15%, that is the time you should have the massive transfusion protocol in place, and it is a ratio of 1:1:1. Point of care testing like TOG can give a clue to the why the patient is losing blood, and hence the blood components can be selected depending on the TOG report. And identification of the blood transfusion. Actually, the slide which I missed was because of identification. So please identify the patient before the blood transfusion is given. The blood group should, because many times patients die because of wrong blood being given to them. So whatever case I wanted to describe also, the morbidity was caused because of the wrong blood that was given to the patient. Fortunately, that patient survived, but we have a lot of reports saying that people die because of wrong blood transfusion. So when you're giving lot of blood in the OR, and still after surgical hemostasis also patients are having lot of ooze, you must think, and if you see blood is going on, you must think of a wrong blood transfusion and take corrective measures for that. So I think it's important as an obstetrician to know that transfusion of blood components is, you must have a transfusion only when the benefits outweigh the risks. Dr. Archana, I took this from your letter to me, never be too busy, and now I think it's relevant. Today is Mother Teresa's birthday also. Never be too busy, not to think of others, and I request, please donate blood, save lives. So I'm sorry for that electrical current problem. And thank you for this opportunity.
Thank you, Sudha. I think we really troubled you a lot.
No
lot of information. So now coming to this plasma donation, I think none of the women can donate the plasma.
Multiparis. We have had nulliparous women coming forward.
Yeah, nulliparous.
Yes.
Paris women. Yes. Even if it is a miscarriage.
No. Yeah. Even one miscarriage we don't take. We ask the history, and if it is nulliparous, we have taken around, I think 3 people have donated so far. We have young, robust, very interested girls coming forward from the college and donating the plasma. But multiparis, I'm sorry, because of this HLA antibody thing, we cannot take the plasma.
Right, a lot of things clear. Any more doubts, Archana? Did you see anything?
At present, one more this thing is there. Regarding biomarkers, I think we have already discussed, ma'am.
That's in the previous chapter.
Yeah. I think we can wind up.
Yes, yes.
Thank you, Shanta ma'am, for your precious time. Thank you, Vindhya madam, for your patience. You have the patience of listening. I call you in between most of the time, many times at 10 o'clock also, and you are so gracious to receive the phone. Thank you, Dr. Sudha and Dr. Anu Acharya, who have given precious time. Thank you, Neeraj sir. Dr. Neeraj has patience. Not only he answered his own questions, but RT-PCR also he joined us in the discussion. Thank you, Dr. Manjula Anagani, Dr. Asha Bakshi. All the best for your elections. And then I just want to thank, most important, all the audience and Dr. Garud Lakshmi madam, who has given us time, and Dr. Narasimha Reddy, who has given us time. Thank you all of you. Thank you for a session. If you are still there, will you like to talk about it? Anything?
No, madam. I think it is best if you close the session for all of us.
It is almost 8:30 going to be.
Thank you for all the help for conducting this webinar, and thank you one and all.
Okay, thank you for inviting. Thank you very much.
Thank you, Neeraj, for staying till the end. Okay, we got delayed.
Thank you.
Lakshmi also.
Thank you.
Bye-bye.